Yat'e, everybody, welcome. And I just want to start off with saying Happy Native American Heritage Month. My name is Olivia Trujillo on behalf of the Johns Hopkins Center for American Indian Health. We would like to thank you for joining our fourth and final part of our four-part webinar series. Today's webinar is titled The State of the Science on the COVID-19 Pandemic and the Importance of Community Health Workers in the Promotion of Vaccines, Community Health, and Resiliency. I would like to take the time now to introduce our first presenter, Dr. Nina Ritchie. Nina was born and raised in the small Greek community of Tappan Springs, Florida. She earned both her undergraduate degree and medical doctorate at the University of Florida, where she has also met her husband, Eric. After graduation, they moved to Boston, where they completed their residencies in the Harvard Combined Internal Medicine and Pediatrics program at Massachusetts General Hospital. They then moved to the Navajo Nation and joined the Indian Health Service in 2012. Nina is board certified in both internal medicine and pediatrics. She initially worked at the IHS Chinle Comprehensive Healthcare Facility for 3 years as a medical officer. She joined the Center for American Indian Health in 2014. She is the study physician at the Chinle, Arizona site and works with the center's infectious disease team. In her free time, she does enjoy exploring the Four Corners area, hiking, camping, photography, which we have utilized a lot of her photos this past year or couple of years. And she also enjoys doing that with her husband and her 2 young sons. So thank you so much for joining us, Nina, and I will turn it over to you, and she will give the state of the science of the COVID-19.
Thank you so much, Olivia. Thanks for having me today. And, I just wanted to give just a brief overview of where we are currently in the pandemic. And then we'll segue into some other topics. So we're going to get to our first slide. So, currently we are about 20 months into this pandemic. And, we just experienced the Delta surge. And in the past few weeks, we're actually having a decline in cases, about a 60% decrease in cases since the peak of the Delta wave or Delta surge. As we've observed during this most recent surge of cases, which has been predominantly due to the Delta variant, there's been an increasing proportion of children who have been infected. Children are the ones who are now unvaccinated and more vulnerable to COVID-19, and children have also returned to in-person school and in-person activities. So it's not surprising that we have seen this increase in children affected. We've also continued to see that many rural and underserved communities are experiencing spikes in cases, as well as hospitalization, even though in many areas of the country, we are seeing a decline in the overall case counts. Next slide. So as I mentioned, that, even with these declining case rates, and even seeing some of these declining case rates in American Indian and Alaska Native populations, these populations still remain, at high risk for infection and are still experiencing high case rates, especially hospitalizations. You can see in this graph that American Indians and Alaska Natives are represented in the yellow curve. So, in contrast to other groups across the nation, American Indians and Alaska Natives remain very vulnerable and are still experiencing high case rates and surges and hospitalizations. Okay, next slide. As I mentioned before, with COVID-19 in kids, we are seeing an increased proportion of children who are infected with COVID-19, especially during the Delta surge. More than 6 million children in the US have contracted COVID-19, and that's including more than 1 million cases among children in the last 6 weeks alone. More than 600 children have died from COVID-19. 158 of them have been between the ages of 5 and 11. There's been more than 5,000 children who have developed a severe multi-system inflammatory condition known as MISC following a COVID-19 diagnosis, which can have debilitating physical effects. And as you can see in this graph, earlier on in the pandemic, represented in the maroon line, that's the age group that's 75 years and older. They were the predominating age group that experienced COVID-19 earlier on in the pandemic. And as we've progressed over all of these months, you can see how that age group is actually the least, the smallest proportion of cases. And the highest proportion of cases are kids, if you follow the colors of the line, are kids who are ages 5 to 17. So that is the highest proportion of COVID-19 cases now is among that age group. All right, next slide. So vaccines for kids age 5 to 11 years of age. So as we've probably been seeing in the news, based on scientific evidence from the clinical trials, an expert advisory committee advising the FDA has recommended to authorize the Pfizer-BioNTech COVID-19 vaccine as 2 doses of 10 micrograms given 3 weeks apart for kids 5 to 11 years of age. And just yesterday, the Advisory Committee on Immunization Practices that works with the CDC, they reviewed the recommendations from the FDA, and they reviewed all of the available data and voted unanimously to proceed to give the pediatric dosing regimen to kids 5 to 11 years of age. So this is very big news. This all just happened in less than 24 hours. And vaccines are already being put in the arms of children across the country right now. As I mentioned before, this is a 10 microgram dose as compared to the adult dose that's 30 micrograms. So it's a third of the dose. Safety of this vaccine has been demonstrated in large trials, and it showed that the children had a strong immune response after vaccination and had no severe vaccine-related side effects. Similar to those who are 11 years of age and older, many of the children who did experience reactogenicity, which is an expected symptom in response to the immune system responding to the vaccine, many of them, if they did have a response, it was just 1 to 2 days of tiredness, headache, maybe fever, muscle aches, chills, kind of the usual side effects that we've seen so far with the COVID-19 vaccine. So they weren't seeing anything unusual. But this is a very exciting time. And just so folks are aware, the number of participants who were in the phase 3 study was over 2,000 for the pediatric trials, 5 to 11 years of age, which is pretty comparable to other vaccine trials that have taken place in pediatrics. And because we've had so much information and data available for kids who are 12 years of age and older, whether from the trials or real world data, now that the vaccine has been available for those older age groups for the past almost year, we feel that the data available is very sound, and the FDA and the Advisory Committee on Immunization Practices felt very confident about proceeding with this recommendation for the 5 to 11-year-olds. Next slide. So where are we in terms of variants? As we know, Delta remains the predominant variant in the United States. This variant is more than 2 times as contagious as previous variants. And it may cause more severe illness in unvaccinated patients. And as we know, vaccines are highly effective at preventing severe illness, hospitalization, and death due to the Delta variant. So regarding vaccination boosters, I'm sure that you've seen this in the news, and maybe some of you have already received your boosters. But as we know, vaccines teach our immune system to fight invaders, such as the COVID-19 virus. However, immunity naturally wanes over time, and this is especially true in immunocompromised or elderly people. on some people who have received Pfizer or Moderna vaccines more than 6 months ago, or the Johnson & Johnson vaccine more than 2 months ago, are now eligible for booster shots. So those who are eligible for these booster shots are people who are 65 years of age and older, people who live in long-term care settings, people who work in high-risk settings, and people with underlying medical conditions. So what do we know so far about COVID-19 and potential long-term sequelae? Most people with COVID-19 fully recover within weeks of the illness, but there are some people who experience COVID or post-COVID conditions, also known as long COVID or post-acute COVID, or COVID-19 long haulers. These post-COVID conditions are a wide range of new, ongoing, waxing and waning health problems that people can experience 4 or more weeks after first being infected with the virus. Even people who did not have significant COVID-19 symptoms in the days or weeks after they were infected can still develop these post-COVID-19 conditions. And these conditions can present as different types and combinations of health problems for different lengths of time. So, I think it's really important to, take a moment to reflect on how the pandemic has affected us personally, emotionally, physically, socially, and it's been really hard, no matter how, as individuals, we've been affected by this. But it's also been an opportunity to show how strong we are as individuals and how strong our communities are. So I think if we want to take a moment and people can enter into the chat, what are ways you have taken care of yourself and your community during the pandemic? We'd be really interested to see, some of the answers you share with us. What worked for you? What's worked with your family? What's worked for your community? So if you guys would like to enter that into the chat, we'd love to see those responses and we can learn from each other. All right, so that wraps up my portion.
Great. Thank you so much, Dr. Ritchie, for that great explanation. I would like to move on to our next part of our webinar. However, I've noticed that you've all utilized or started utilizing the chat, so keep doing that. Put your questions in there. If you do have any, we'll get them answered, as well as keep letting us know where you're calling in from. We would love that information. So with that said, I'd like to move on and introduce Ms. Cheryl Archuletta. Michelle is an enrolled member of the Lone Pine Paiute Shoshone tribe with an ancestry in the Okayawenge. She is currently the Indian Health Service National Community Health Representative, Consultant, and Community Health Team Lead. Michelle has an extensive background in health promotion and community-based programming at the local, state, regional, and national levels. Her professional interests include health coaching, Indigenous story work, and advocacy for the advancement of the field of community health and CHRs critical to the front line of health and healthcare. So thank you so much, Michelle, for joining us today, and we look forward to learning more about the Community Health Representative Program.
Oh, great. Thank you, Olivia. And thank you, Dr. Ritchie, for all the great information regarding the state of the science with COVID-19. I think it's very helpful in seeing, how this disease has I guess, evolved, and how all of us have a part in working to prevent it and control it. So thank you very much. So as Olivia said, I get to pick it up from here. My name is Michelle, and I'm very honored to be a part of this panel presentation. Let's see. And as my part really is focusing on and introducing to us as participants this concept of community health. And I want to highlight how then CHRs in tribal communities are stepping into their roles in communities under various community health worker models. And so what I would like to do is take this little bit of time to provide a wider net about our role under the community health worker field, but how that impacts this broader strategy called community health under the public health umbrella. So the field of community health reflects the needs of the community, and it exemplifies the best of public health research and methods to achieve a shared goal of improving health. So I want you to think about this and listen one more time. It reflects the needs of community, and it exemplifies the best of public health research and methods to achieve the shared goal of improving health. And there's some core principles of community health that are built on an understanding of these core functions. And so I'm just going to go ahead and mention them briefly, but really what they are is at their core, it's looking at the intersection of the community's needs. So take a look at this picture and try to see visually the words that I'm saying. So when we work in community health, we are working at the intersection of community needs. We're working for the community's understanding of and priorities for health, and for the best methods for documenting any type of intervention activity that we may deliver in our community. So this is a quick example that I like to show this Just Move It slide. And for the 10 years that I was working in the Tuba City service area, this was a large community event where it really was reflective of culture, the values of community people, of Native people, family, the resiliency, the protective factors, the environment, health. I mean, this to me is really what we do in the work of the CHR program. And we're going to talk a little bit how when I was in the area of health promotion, it was the Just Move It event, but I really do feel in the area of the CHR program, it is centered around this family spirit program. And so now I want to move forward. So this is a slide that really is comes from our CHR webpage, and it's how we understand as a CHR program how we talk about the community health program. And we talk about it as a unique concept for providing health care, health promotion, and disease prevention services. And even when I was in the health promotion field for the last 20 years, you know, I just cannot separate, you know, oh, I only did this in the field of health promotion. No, it was very integrated in terms of indigenous Native communities, this concept of the CHR program. So this to me is the merging of what we do with health promotion, disease prevention, healthcare in the CHR program. So then I like this slide. And I like it because I feel like it says, and it really is a visual, that over time, CHRs have demonstrated how they assist and connect with communities, and how their work has become essential to the spectrum of tribal-oriented, community-based health and health services. So what we see and what we know about CHRs is that they're great advocates. And in part, this comes from their close connection to the community that they're working in, because many times they're from that community. And so they are also known as the trusted messenger of the community. And I want to say there's three things that come to mind that I have heard in the news coming from the CDC is for us to get ahead and to continue to I would say, stay ahead of COVID-19, there's three things. We need to stay and communicate information through that trusted messenger source. So CHRs are one. Our providers in the field, like Dr. Ritchie, our allies at JHU, they are another. So these are trusted messengers that we trust the science, we trust the information, we trust the knowledge. Stay one-on-one in terms of communicate and dialoguing as a CHR, as you work with families to try to help change the narrative for people to continue towards vaccination, booster shots. You know, they might have questions. So that's, you know, stay one-on-one with, you know, and share your experience. And the other one is, as CHRs, we're natural educators. You know, that's part of our role, is to share the latest information, partner up with the medical community, and really be out there in the community to help educate and promote. So summing up, as the CHRs out in tribal communities, your duties are as diverse as the communities that you serve. And I just really look at these four circles. That's the CHR emblem. And each one of these are, from the top left is from Hopi. Then the top right is Navajo. Coming down, you have Ho-Chunk, and then you have the Kiowa. So there's similarities, but yet there's differences. And that's just what communities are. So just real quickly, I wanted this to also, it's important to keep educating. Educating, sharing knowledge about who we are as a CHR program and what field we fall under, and that's the community health worker field. And so the Rural Health Information Hub has identified 6 program models. I'm not going to go through all of them. I'm just going to say, as the CHR program, we fall under that member of the care delivery team. And we're working alongside medical professionals to address health issues. That's pretty much, I would say, where we're at. But that's not to say we don't also move into the screening and health educator model and the outreach and enrollment agent model. And I want to just take us through those couple of slides to highlight that, and you'll see this. So as CHRs, many of what you have done to be an ally, to be a team member, to help your community has been through screening and the health educator model. And you've done that through mitigation, you've done that through community education, and you've done that through preventive messaging. And being out there in communities, going door to door, putting up information, taking CDC information, information from JHU, and translating it back to families. So you really have done that job. On the other side, the outreach and enrollment agent model is really important for this particular presentation, as we as CHRs hear the information presented by Dr. Ritchie with the state of the science, but then our next upcoming presenters. And so this is really about, as a CHR program, our natural, our own best practice of using our CHR skills with outreach, engagement, working with families, and really targeting this maternal, infant, and just child health component. And so using this model, outreach and enrollment, the IHS CHR program absolutely supports tribal families and communities to improve maternal, infant, and child health. And we do this through our partnership with Family Spirit, because we know that as CHRs, we're able to connect parents and families to their own personal and cultural resiliency. And so that is something that we're going to start to hear now with our next 2 speakers. But I want to also just say, so with that, it's my time to pass it over to Tara, where she is going to shine the light on the importance of supporting, fostering, and coaching Native families, using family spirit as an intervention strategy. And so on behalf of the CHR program, I want to say thank you. As CHRs, your work is important, especially when it strengthens the foundation that supports healthy futures for Native family and children. So thank you very much.
Awesome. Thank you, Michelle. So good afternoon, everybody. My name is Starbunenko. I am joining you all today from Sacramento, California, home of the ancestral lands of the Miwok, Maidu, and Nisenan people. I have been working with the center for a few years now, and prior to that, I was actually a community health representative for over 10 years here in Sacramento. And not to date myself, but I remember way back when we did a whole 3-week training in person for CHRs. And so the CHR program is very, very near and dear to my heart. I'm very honored to be here and to meet with you all today to talk about the Family Spirit Program and our capacity during COVID-19, our work with IHS and all of that wonderful stuff. So to start us off though, I know we have about a little over 100 folks joining us today, and I would love to see in the chat how many of you are familiar with Family Spirit or are part of the Family Spirit team as an affiliate using the model at your site. And so while you all, if anybody would like to share that in the chat, that would be wonderful. And I will keep on going. So Anna, you can go ahead and change over for me. Thank you. So the Family Spirit Program, I know Michelle talked a little bit about it and our partnership with IHS, but Family Spirit is very unique because it's the largest and only evidence-based and culturally tailored home visiting intervention program that was designed specifically for and by Native American families. And I'll talk a little bit more about where that all happened. But the intervention really is tailored to be delivered by Native American paraprofessionals. So that means community health workers and community health representatives like you all. And this is a core strategy so that we can support Native parents from pregnancy to 3 years old with folks who identify with them and who are from their community and share a lot of similar practices and traditions and stories with them. So in our chat, I see Laura Robinson as part of our team. Yep. And then Kathleen, I remember when you trained a couple, I think it was last year, right? With White Mountain Apache. So thank you. So Family Spirit really covers a lot of stuff. We offer, this really comprehensive curricular package that health educators, family home visitors, and community health workers can take into the home to share with families all information to help build skills and support them as parents in all of these different topics, right? So for example, maternal care, which is pregnancy, breastfeeding, sexually transmitted diseases, drug use, family planning. We talk about infant care, immunizations, and nutrition, and then parenting skills around learning how their child's development, preventing injury. We know that's a big one in Indian country, as well as the use of routines and monitoring your children and really kind of being in tune with how they are growing and how they are developing as wonderful young people. And then just life skills. There's a lot in this curriculum that includes support for developing life skills, like just simply setting goals, right? Budgeting, coping with stress, and communication. Go to the next one, please. As I said, we want to recognize that capacity or resources are often very low in our communities. And so particularly the shortage of nurses. So really when we talk about working with paraprofessionals, there's no specific licensing or certification, professional certification or schooling that is required to use this curriculum. It's really developed to be delivered and supported with families from the local workforce. In addition to that, the Family Spirit, when it was developed, it really took a culturally grounded, strategic way about doing things, right? So including familiar stories, creating dialogue between families, Excuse me. I got that in the background. We are intentional about using Indigenous illustrations, and then also, implementing cultural activities that are local to the tribes. Family Spirit works with the sites to really build a cultural approach with the curriculum that is tailored to what their community practices are, or their needs and capacity is as well. Go on to the next one, please. Thank you. The model is developed to be serving families from pregnancy to age 3. So really that's, a little over 3 years old, and it's a really important and critical time to be sharing the lives of our families. Here we see outcomes from the research around parenting, around outcomes with the moms, and then even the children as well. Some of them, even include decreased mental health challenges like depression and substance use. And then we saw, even with the children and with the moms who were teens or families who were teens, fewer behavioral issues as a result of this education and parenting skill support in the home. All right, here in this graphic, we see kind of where Family Spirit is. And just to make a note that in this teal or bluish states, these are where all of our Native affiliates are located. In the yellow are where we have several non-Native communities now, or affiliate groups and sites that are implementing Family Spirit. And oftentimes these are with urban communities who are a mix of ethnicities, African American, Latino or Latina, and then even some Asian American communities as well. And when we look in Minnesota, you see that it's red, and that's where we have both Native and non-Native communities implementing Family Spirit as well. Go to the next one, please. Perfect. Okay. So training, right? Between 2013 and 2021, we have trained over a total of 195 CHRs across 51 sites. That's a lot of people, that's a lot of folks, right, that we have worked with to use Family Spirit in their communities. Some of the sites include the Blackfeet CHR program, which Cheryl's here from. She's going to join us here in a little while. Colorado River, Ho-Chunk, Hopi, and a few others. I think there was somebody here who had said they were from, Kathleen said she's from White Mountain, so we see that her on the list as well. So then this is growing, it's continuing to grow as we work with other IHS CHR sites across the nation to utilize Family Spirit in their communities. So Family Spirit, the training that we have, it's pretty rigorous. Most of you who have been through it know. And it really does provide that support to utilize Family Spirit in your communities. But once training is over, that's not when our engagement stops. So we really, Family Spirit is a relationship-based model. So we really highlight the need and the impact that the relationship that CHRs or health educators have with the families. But we continue that on to the relationship that Family Spirit has with the sites that we work with. And so our level of support, our ongoing support is very high as you continue to utilize Family Spirit in communities. So all of our sites receive access to Family Spirit program resources. We have an online portal, ongoing training and technical assistance is provided. We also offer opportunities, throughout the year for professional development and skill building, or continuing to work on improving those skills. We have an electronic platform, so a lot of folks are using RPMS or some sort of EHR system. But then for those who are not, or who don't find that it is able to kind of connect with their Family Spirit work, we also offer an implementation support platform called Care4. And then just ongoing on a quarterly basis, we meet with all of our sites to talk about, challenges and successes that they've experienced over the quarter, as well as any reporting that is completed too. And then Family Spirit is also working on developing a digital curriculum. So that's coming up soon, and will really support sites who not just using the big box that we have, but also, those those of us who are now doing mostly virtual visits due to COVID-19, we're going to have a digital platform that will help support sharing this information with families if we're not able to meet with them in person. You can go to the next one. In addition, those things are open to all of our sites, so whether they are IHS sites or not, but specifically for our active IHS CHR sites, we are looking into the next several years and offering training slots that will be available to specific programs who are active, CHR Family Spirit sites, but also a community of practice. So, this is something that is coming soon. We're working on developing this, but for those of you who are already Family Spirit sites with this, with your CHR program, there will be opportunities to join a community of practice where you can gather and learn and share with other CHRs from other sites across the country. So continue to look for those. We're still in the planning phase now. We're hoping to launch something in the fall of 2022. Now, talking a little bit about Family Spirit's response to the COVID-19 pandemic. Well, one of the first things that we had to do was really pivot and develop quickly a virtual model of our training, right? So folks still needed to be trained, and we did that very quickly. And we've learned a lot over the past year and a half about how we can be effective even virtually in training new health educators, new CHRs to utilize Family Spirit. In addition, the center worked really hard to develop a Family Spirit lesson that is dedicated to COVID-19 and providing education and support to families during those times. So, we can work with families and share this lesson that has a lot of information, particularly a lot of the questions that you all have been asking throughout the chat as well. We've provided a lot of training and guidance around social distancing and virtual visits. So, webinars specifically on how do we even do a virtual visit? What if we don't have video? A lot of us are rural. We don't have the opportunity to do video. So how can we do that? How can we kind of be flexible and work with our families and meet them where they're at and meet their needs during this time that's very stressful? We also talked with Family Spirit health educators and CHRs about wellness and self-care. We know, I think Michelle said that, family or community health representatives are part of the community, and things shut down during the COVID-19 pandemic, but CHRs did not stop working. Let's just be honest, right? So we heard a lot of I'm still going out to deliver medication. I'm delivering food boxes. We're making sure people have the right sanitation supplies and masks and things like that. And that didn't stop with the COVID-19, pandemic. That didn't stop in that 2 weeks that everything was supposed to, magically disappear in. And so Family Spirit really responded greatly to how we could support community health representatives and health educators that are in the field, kind of shifting their work to provide services and support to their families. There are additional resources on the Center for American Indian Health, the JHU site. So there are infographics, there are links, there are books, storybooks to share with families. There are answers to questions about COVID-19 are there to provide support to your communities, and most of it, I think all of it's free. So please take a look at that. I think I can put that in the chat box. So here's a link to that if anybody wants to take a look. And then our partnership with Indian Health Services has been ongoing to provide education and support for CHRs at multiple levels. And then there's a storybook. I think I quickly mentioned that, but there is a children's storybook collection or books for families to utilize in the home, or CHRs to utilize even with families that talk about COVID-19 and kind of how we can support our children in kind of understanding and grasping what's going on today. Okay, so I think that's it for Family Spirit. I didn't see any questions specific to me that I could tell, but again, Family Spirit, myself as the Director for Training and Technical Assistance, we're always available for questions and support. But now at this point, I want to talk a little bit with Cheryl Ground. So I'm honored to welcome Cheryl Ground. She's Blackfeet CHR Supervisor. And she's joined us to share her experience with the Family Spirit program, and particularly during the pandemic, right? So Cheryl, can you introduce yourself and talk a little bit about how you're using Family Spirit for your community? You're on mute, my dear. See, even after a year and a half, we're still all trying to learn all this stuff. It's okay.
I always make sure it's off. My name is Cheryl Ground, and I'm very honored to be a part of the panel. A Blackfeet CHR. I've been working with Family Spirit for about 3 years. I mainly worked like in the administrative part, but now I'm in the home visiting. And so it's exciting. We really had a lot of support from Family Spirit, Tara, throughout the pandemic. They just kept us going on Zoom, on training us and giving us a lot of information and how to do things differently. And oh man, they were a blessing to us, really. We've, you know, in Indian country, we're not too up on technology. So, and then also the state of Montana, our funding source, we got some CARES Act funds through them and was able to purchase our clients, our participants, tablets and data. And so that just really set us up to, you know, be able to do things through technology. So what we really did is we just start calling them on the phone and going over the lessons with them, and which we still do at this point. We're social distancing and still have a lot of COVID cases. And so we just start doing that. And we also purchased the ASQ online database, and it's not very expensive. And so with the tablets and everything, we're able to send them their ASQ questionnaires. It's really simple. They can fill them out even on their phone. And then it just comes back to us, to the database, it scores it, and it just does everything for us. And that's really awesome. So we're getting that going pretty good. Just the CHRs, you know, they're always there to help provide the health education, get it out there, transportation. They've always been a big support of maternal health on the reservation.
Cheryl,
just, you know, redoing, pardon, go ahead. Go ahead, Tara.
I was just going to say, I know you mentioned the tablets and being able to get some devices for families. Can you, I know some programs were able to do that, but it is a great need amongst most programs. You know, with the pandemic, families didn't have technology or the devices. How were you able to do that? Or what resources did you utilize to offer those to families?
Well, they purchased it for us through the CARES Act funds. And so that's how we were able to do that. And then the other thing too is, you know, as long as they also, our funding source also buys the participants cell phone minutes every month. And they also buy them gas cards every month so that they can get to their appointments. They don't have to ride with other people, or, you know, it's kind of to be more safe and to get to their appointments. And also, just having the cell phone, they're able to do those ASQ questionnaires on their cell phone. They really don't even need a tablet. And they're able to, we chat with them, you know, face to face on the cell phone. So the cell phone kind of became the big major, you know, device. And so we just text, we message. It works really good. They respond well, you know, and so thank you guys for helping us get all lined out.
Yeah, thank you, Cheryl. So it sounds like, you know, a big part of your work in during the pandemic with the CHRs was definitely making sure people had the technology that they needed and those devices. And it sounds like, you know, families were really responsive and they were utilizing those, you know, to communicate with the CHRs. And you mentioned the ASQ questionnaire. I just wanted so everybody knows what that is. That is actually, it's called the Ages and Stages questionnaire. And it's a screening that Family Spirit recommends for childhood development. So it looks at the cognitive, social, and physical development of children through age 5, right, through 0 to age 5. And there is an electronic way that you could do it, so families can. It's very easy, you know, if the family is open to it, they can complete those questions based on what they observe with their children. And Cheryl's done really great work in utilizing those during the pandemic.
And what's good too is with the ASQ, they also give you the activities that you can do with your children. So we put them in the back of the Family Spirit workbook. And so, you know, it just tells them different activities they can do with their children, and it's age appropriate at what age. So it's pretty good. And
so those activities, so Family Spirit curriculum has a workbook, right? And we provide these kind of, for each lesson in the or each lesson in the curriculum, they get a workbook page and maybe some activities to do. So how did you get those to families? What was the easiest way that you were able to kind of give materials or support families with utilizing the materials for Family Spirit?
Okay, so we just took the workbook, in our planning department, they copied it for us. And then we put those activities in the back of it. And so I deliver the workbook, and I also deliver the at the time of intake, you know, we deliver them the workbook. And so then when I call them and and then we, you know, the actual lesson schedule, that has really become to be awesome. So we give them that too. So then they actually know where they're supposed to be because of that lesson schedule. It goes by the age. Starts out with pregnancy and then the age of the child. And so they actually know what lesson they should be on in that workbook. So I just communicate with them through that, And then when I call them, they know, you know, where, because they have a copy too. So in their packet, I gave them a brochure. I give them that, their schedule, they get their workbook, the nutrition workbook, right at the initial setup.
Yeah, so at the beginning of them becoming part of the program, they get these materials, and then, you know, as you're going to be doing lessons or whatever, you're dropping off the other materials if needed. And so when you call or when you have a virtual visit with families, they already have those materials in front of them to follow along for the lessons, right? Yeah, that's really important. That was a really challenging thing for people to kind of, at the beginning, for us to think like, how are we going to get this stuff to people, right? So you're dropping off masks, might as well drop off some worksheets too, right?
Yeah, and I drop off their cards every month, you know, for their cell phone and their gas. So if there's anything else I have to deliver, I try to do it all at one shot so that we're not, you know, interacting too much, because our moms, a lot of them aren't vaccinated and the babies aren't. And so we try to be really careful, and CHRs are really good about providing us with the PPE and, you know, everything to be safe to make that contact.
Awesome. So do you, Cheryl, do you have any advice for, you know, any advice for programs who are hoping to use Family Spirit during the pandemic and kind of work with the challenges? Any advice that you might have?
I just think that we really have a good team that works with us. And so, you know, you've just helped us work through everything. So that's my advice, is just to get on the trainings. You know, you have them every month and you give out the schedule, and those just really help you go along and, you know, get through the bumps.
Awesome. Thanks, Cheryl, for that. I appreciate that. So just keeping in communication and engaging with us. We really work to provide a lot of support individually for your questions and stuff. So thank you, Cheryl. I really appreciate you sharing everything with your experiences and your leadership. I'm going to pass it now back to Olivia to take over for us so we can look at some questions for the remainder of the time. Okay. Thank you, Cheryl.
Thank you.
Great. Thank you so much for that great discussion and insight into what's happening on the ground in the communities. I know you all have been putting your questions in the Q&A box, and I'd like to thank Dr. Ritchie as well as Dr. Laura Hammett, who is our current infectious disease director at the Johns Hopkins Center for American Indian Health, who have been on it answering the questions in the chat. So thank you so much for that. But the other questions I'd like to address, and then we can go forward if anybody else has any questions they want to add. But the first one is from Lisa. What is the average length of your community health representative / worker training? I believe is for the Family Spirit program, but I don't know if you have any specific trainings as well, Michelle, that you want to add for that.
So I will say for Family Spirit, the health educator training. So usually to be certified as a Family Spirit health educator or CHR, then it's about 2 weeks online doing your own thing. You know, we have an asynchronous part of the training for 2 weeks, and then we meet live on Zoom for 2 weeks, 4 days a week for a few hours per day. And then after the training is over, we meet with sites every month to support them in using Family Spirit in their sites.
Great, thank you. I saw Michelle give a thumbs up, so we'll move on to the next question from Margie. Is there a confirmation on when to get a vaccine after COVID-19? So I'm going to direct this to Dr. Ritchie.
Yes, so I'm sorry, I was actually typing the response in, but I can share it verbally as well. So as long as the infected individual has completed their isolation period, so typically for most people who've had mild to moderate disease that does not require hospitalization, that's 10 days of isolation. After you've completed that isolation period, you can proceed to get your COVID-19 vaccine. If you've had severe illness and you've been hospitalized, that isolation period is much longer. I believe it's 20 to 21 days for someone who's had severe disease and has been hospitalized. I know that earlier on in the pandemic, it was recommended that if you had COVID-19, you should wait 90 days after your infection. That recommendation was made because of the scarcity of the initial vaccine supply. So the vaccine rollout, there was a prioritization, only certain groups were available because we did not have enough vaccines to cover everybody who wanted or needed a vaccine. But that's not the situation we're in now. We've got many vaccines available to anybody who wants them. So you do not have to wait 90 days after your COVID-19 infection. You just have to wait until you're out of your isolation period.
Great, thank you. We do have a question for Michelle. So what do you think the biggest strength or contribution of the CHR program is in tribal communities?
Oh, I think it's the lived experience. I would say that is a definite protective factor. I think there's nothing better than working for your community. And I think that CHRs who give back to those communities, I mean, I've seen this, I mean, they are, they're role models, they're educators, they're grandmas, they're staying with these CHR programs from coming out of high school, I mean, going through, their elder years. I mean, they are really able to impact their tribe, their community in so many ways. I'm sorry for taking so long to answer that, but I would say that.
No, that's great. Thank you for that. With that said, I know there's a couple of questions left, but in terms of time, we want to be mindful of everybody's time, and it is the end of the day here on the East Coast. So we would like to thank you all for joining today's webinar, and thank you for participating, getting your questions to us. And as we wrap up, we'd like to let you know that there will be a survey that will be sent out after this webinar. So if you could, please fill it out. We would love to hear your feedback on how we can make these types of discussions better or get more information out. So thank you again for joining, and we appreciate you all. Have a good day.